Hello, welcome to our special live streaming series, COVID-19 Frontline on CGTN. I'm Zhou Yun. COVID-19 Frontline is a special live show for medical experts from China around the world to share their thoughts and experiences on fighting and containing COVID-19. And apart from medical expert discussions, we also take questions from our followers on various social platforms, such as CGTN app, the official website, CGTN official account on Facebook, YouTube, Twitter, and Sina Weibo. So feel free to leave your questions and comments on those platforms with the hashtag of my opinion on COVID-19. We look forward to your participation. And today, we have a very special array of guests from China and Brazil. And all the doctors today on the Chinese side came from Peking University Third Hospital, and they all have frontline experiences in fighting in Wuhan, which was the epicenter of the outbreak here in China. And now it is my great honor to introduce to you to our followers on your social platforms, and hopefully the experience shared today between the doctors of two countries can help Brazil, who are now holding the world's #2 tally of cases, to help them better defeat the diseases of COVID-19. And now it is my great pleasure to introduce to you all. First of all, we have Dr. Shen Ying, who's the Vice President of Peking University Third Hospital, and also Professor of Pulmonary and Critical Care Medicine. Thank you so much for joining us, Dr. Shen. And also we have Dr. Li Shu, who's the attending physician of emergency medicine, also from Peking University Third Hospital. Thank you for joining us, Dr. Li. And we also have Dr. Li Tao, who's the attending physician of critical care medicine from Peking University Third Hospital. So thank you so much for joining us, ladies. And I just noticed that all the doctors joining us from China are ladies, and all the doctors joining us from Brazil are gentlemen. So now it is my great honor to introduce to you our gentlemen here today. So we have Dr. Luis Maboison, who's the professor of anesthesiology from the University of Sao Paulo Medical School, and also the medical director of the surgical of ICU. Thank you for joining us, doctor. And we also have Dr. Daniel Wagner Santos, who's the infectious disease consultant from São Luís Hospital from Sao Paulo. Hello there, doctor. And also we have the Dr. Victor Carabo, who's the head of medical management of ICU from America's Medical Services. So thank you for joining us, doctor. And we also have Philippe Eric Silva, who's the intensivist and specialist in ECMO from the Hospital of Samaritano Barra. Last but not least, we also have Dr. Emmanuel Saguero, who's the team leader of ICU and also from the Hospital of Samaritano Barra. So thank you so much, everyone, for joining us today. And also today we have the great pleasure and honor to have a very, very special, a distinguished guest joining us today. And she is also a lady here from China. And it's Dr. Qiao Jie, who's also an accommodation of the Chinese Academy of Engineering and also the president of Peking University Third Hospital. And she also went to Wuhan to fight the battle at the very, very front line. So thank you so much, Dr. Qiao, for joining us today. It is our great pleasure to have you with us. So first of all, can we have you to deliver a few remarks and share your understanding of your experiences in fighting the disease? Please, Dr. Qiao.
Yeah, good evening and good morning, everyone. Thank you to CGTN for organizing this connection. We will have in-depth communication between Peking University Third Hospital and Brazil to share our treatment experience about COVID-19 in Wuhan and in Beijing. And yesterday, June 7th, as the WHO chair for tenders issued the warnings as record-breaking 136,000 cases were reported worldwide, and warning that the new coronavirus pandemic is still worsening globally, despite reduction in infections and death across Europe. China issued a white paper also yesterday titled Fighting COVID-19 China Infection to keep a record of the country's effort in its own fighting against the virus and to share the experience with the rest of the world. And actually, my team, my colleagues, you see the Shening and Li Chao and Li Shu, who are our team and also join this battle. So today, it's our pleasure, responsible for and also actually we are obligated to share our experience around the world. And our hospital is the third hospital affiliated to Peking University, also is led by the National Health Commission. So this time, when the pandemic, the virus pandemic in the Wuhan, Peking University organized more than 400 healthcare workers to support Wuhan from January 26th. The team fight against COVID-19 for 72 days for cure severe and critical patients. And actually, our hospital in Beijing, every day we have 16,000 outpatient clinic average every day. So you can see at that special time in this spring, we have to do our basic work for cure the patient in Beijing, and also our team have to as a soldier back to the virus in Wuhan. And also actually in Beijing also there is some suspected patient and diagnosis patient and we transferred to the designated hospital. So actually we have a 3 lane how to continue to work for that. And in the hospital there were 137 professionals who operated 3 isolated critical ward for the COVID-19 and saving lives. And actually, it's a very important as a MDT cooperation team with the help of the other leaders like consultant center for Peking University medical team established in Wuhan, and also the consultant experts in the Beijing our hospital by remote connection, and also consult in the other 23 medical teams from all countries supporting Wuhan, and also including the daily cases diagnosis within our own medical teams. And other important things we think is we pay close attention to the infection control, and which ensure that the zero infection among the entire medical teams. I think it's important things to help protect ourselves and then protect the patients. So we always say these times which is the fight against the pandemic is not only the accomplished conducting by more than 42,000 staffs dedicated of the medical ed team in Wuhan, but also the achievement of covered efforts, our 1.4 billion people across the whole China. So we also think the whole world will also get then the battle, because the sun always shining against again after a storm against the COVID-19. As long as we can unite in pursuit of our common goal, and we will be overcome all our current difficulty and challenge and build a better world for all. So that's also as important things today. We share the experience each other, and we already have a chance to share the experience with America and the England and also the Italy and the Canada, and we've already held more than 30 international section for sharing experience. We learn each other. So thank you again, have this chance to share with Brazil, and have hope that everybody will have a good health. Thank you.
Oh, thank you so much, Dr. Chow. I was very, very impressed with some of the numbers that you mentioned just now, like the 400 medical experts sent from Peking University, and also they stay in the front line for over 2 months, about 72 days, and also about more than 30 sessions in the held on international cooperation, international exchanges. I think really these are really, really touching, because you said your colleagues are the real soldiers at the front line, and I think they're not only real soldiers; they're the real heroes who help us, who help the country, the people here in this country to fight this pandemic and make so much achievements within a relatively short period of time. So I really want to thank you and thank your team for what you have done, for this incredible bravery and also incredible medical skills for bring us here, and also for making what it is today happen. So thank you so much, Dr. Chow, for sharing with us your insights and your experiences. Thank you so much.
Thank you.
So without further ado, I would just like to kick off our Q&A session today. So gentlemen from Brazil, if you have any question for our Chinese doctors, please feel free to go. Or maybe we can start from Dr. Victor Gravo. Do you have any question? Please go ahead.
Congratulations for the task force. Actually, amazing numbers. But I have some questions about actually in the management of mechanical ventilation in those patients, because as we see in the papers, and we have a high mortality rate here in Brazil, unfortunately, in public service, about 700% of mortality rate here, according to the last numbers. In private, we also have high mortality rates, about 56% of the patients proceed in mechanical ventilation. And I would like to know about your experience in those patients, and about how you manage these patients, if there is any special situation or different approach from arts, and if there is anything different in your opinion about those patients.
Okay, so it seems there are lots of questions. Maybe we can start from the first one, right? Why the mortality rate in China is relatively low? Can we start from that, and then we can turn to other approaches of treating patients? So our doctors from China. So who can answer the first question?
Actually, we don't have really low mortality rate. Our mortality rate is not low. Actually.
So yes, we can start from the first question. I think that why the mortality rate in China here is a relatively lower than, for instance, the mortality rate in Brazil. So maybe we can have doctors from China answer that first question, and then we can move on to the other questions raised by Dr. Krabel.
Yes, can you hear me?
Yes, we can hear you.
Yeah, Dr. Li will answer this question.
Okay.
Actually, we don't have a really low mortality rate, and our government asks us to find the patient earlier and to treat them earlier, and then we have so many doctors and nurses to help them. So maybe
Dr. Li, I think you need to turn up your voice a little bit, because we can't really hear you clearly. Can you speak a little bit louder? Thank you. Or you can get closer to the microphone.
A problem with the microphone, so can you hear us now?
Yes. Yes.
Okay.
Yes, please go ahead.
I would like to take this question first, and maybe Dr. Li can follow up with my answers.
I think we have a relatively high mortality rate at the initial stage of the pandemic. I think the reported ICU mortality rate was around 52 to 70%. I think just the same as the situation now in Brazil. I think it might, based on several factors that have impact on the patient survival rates. One of them would be there were a large amount of patients at the initial stage who were waiting for admission. And second, we have a shortage of supply of medical equipment and medications at the initial stage of the pandemic. And also, I think some of the patients, they progress rapidly during their clinical course, and they develop severe hypoxia and shock and MODS. So I think it's reasonable, or it's predictable for mortality rates around 50 to 70%. I believe.
Mm-hmm. And then our government will soon announce the guidelines, so we can get our regular treatment very properly. And then at the last stage of our treatment, we have about 30 ECMOs from all around the China, every province of our country will give the ECMOs to Wuhan, so we can use this recruitment to rescue the life of our patients. So we can reduce the mortality rates at the last stage of the pandemic.
Okay, so it seems that the audio from Peking University Third Hospital is still a little bit low. So I really want to ask the doctors from there. So please, when you talk, please turn up your audio a little bit, because maybe for some of the doctors in Brazil, they can't really hear very clearly. I can hear it, but I think it's getting better now. So thank you so much. So now other doctors, if you have any questions, feel free to jump in and raise them.
Can I make a question?
Yes, please go ahead, doctor.
Okay. Well, as we can see, the patients that develops a severe respiratory failure have a much higher mortality than the patients with a more light form of disease. One question we usually have to ask here in our institution, and now we have about 300 ICU beds dedicated to COVID disease. One of the questions I'd like to ask you is, what criteria do you use to wean the patients from mechanical ventilation and extubate the patients once the COVID respiratory failure is different in its behavior, in its physiological behavior, from a ARDS associated to other diseases? What the criteria used to wean the patients from mechanical ventilation? Thank you.
Mm-hmm.
Thank you for your question. Can you hear me, Dr. Professor? Okay. First of all, because the extubation is frequently associated with some coughing, it is considered an aerosol generating procedure.
Hello.
It seems we might have some technical issues now with the Chinese hospital. Let me check with my colleague. Yeah, I think now they are back. Yes, I think we just lost your signal. And now, yes, please, Dr. Li, yes, please continue.
First of all, the extubation is a procedure that we can consider the aerosol generating procedure. So first of all, we should wear the PPE to protect ourselves. Then the extubation should not be performed until it has been determined now that the patient's medical condition is stable, a winning trial has been successful and the airway is patent. And any potential difficulties in re-intubation has been identified. Then comes to the coughing strength and the secretion clearance. It is the ability of the patient to cough, the strength of a cough, and clear their own secretions following extubation should be assisted prior to the extubation. Then there's some difference in the winning. In our practice, we suggest closed system and not using a TPS trial for the SBT, the spontaneous breathing trials. The practice varies and may include higher criteria for passing the SBT trials. For example, some experts, some of our Chinese experts, use the lower PSV parameters. For example, 0 to 5 centimeters of water column, rather than the typical 7 to 8 centimeter of water column during the trial, while other experts promote SBT for longer periods, for example, 2 to 4 hours, rather than the typical 2 hours. In addition, we prefer extubating patient directly to low flow oxygen, or rather than the high flow oxygen delivered via the HFNC or the non-invasive ventilation, which may which may reduce the risk of the aerosolization. And when it comes to the cough leak test, if there is clinical suspicion for upper airway edema, such as the fluid overload or the presence of a risk factor for the post-extubation stridor, such as prolonged intubation, greater than or equal to 6 hours, or the patient's age is elder than 18 years. So performing the cough leak should be weighed against the potential risk of the aerosolization. And there's our criteria. So we met the required criteria. First of all, the cause of the respiratory failure has improved, and our pneumonia is recovering. The second one is we should make the adequate oxygenation. This may indicate by either oxygenation index greater than or equal to 150 millimeter of mercury, or an peripheral oxygen saturation greater or equal to 19%, while receiving a fracture of inspired oxygen less than or equal to 40%, and a PEEP less than or equal to 5 to 8 centimeters of water column. And then the third one is the arterial pH is higher than 7.25. And then the fourth one is we need hydrodynamic stability without myocardial ischemia. And then the last one, the patient is able to initiate inspiratory efforts. And there's three optimal criteria. The first one is the patient is preferable a hemoglobin level greater than or equal to 70 to 80 milligram per liter. And then the core temperature is less than or equal to 28 to 28.5 centigram. And the last one, the ideally the patient have extubated awake, alert, or it can follow your commands. And we prefer their Glasgow coma score is greater than 8. That's all. Thank you.
Okay, thank you. Wow, these are really lots of criteria. Hopefully, it's helpful for you, Doctor. Yes, Dr. Santos, you have many questions, right? So yes, please feel free to go ahead.
Yes, good morning. Regarding the treatment of COVID, in our hospital, you don't use anymore chloroquine, azithromycin, ivermectin, or nitazoxanide. We don't have any antiviral drugs in Brazil too, as favipiravir and remdesivir too. But in severe cases, in the inflammatory phase of COVID, we have the opportunity to use blockers of interleukin 6, tocilizumab, and in our center, we are in a randomized trial with sarilumab, comparing with placebo. And I would like to know if in China today, at this moment, what do you think about these drugs? What is the experience of use interleukin 6 blockers or other medications that interfere with the inflammatory phase, such as kinase protein blockers too? Do you think that do you have any data about the impact in the mortality in severe patients in China? Because we don't have the data in the world.
Okay, let's see if our doctors. So maybe the first question first is about the medicines, the medication that has been raised by Dr. Santos. Do you have any experience in treating patients with those medicines, and how effective are they, or what kind of effect have they shown on trial? So yes, doctors.
Thank you, Dr. Santos. I would like to take this question. I think during our treatment with our COVID patients, we have tried, like you have mentioned, hydroxychloroquine and chloroquine for both our moderate and severe critical cases. I think we have 60 to 70 patients enrolled in clinical trial of that drugs. And we saw some of the safety and efficacy for the patient treatment, but the result is remain unclear. So we don't have further recommendation for those medication. And for another drug that you mentioned, like interleukin 6 pathway inhibitor, I think I should say we have limited experience for those medications. Although it was written in the national guideline of COVID treatment, we have only used empirically for 3 or 4 patients. All of them were critical patients. If I were not wrong, 2 of them unfortunately didn't survive during their hospital stay, and 1 of them were discharged successfully from the hospital. So we have a really few experience for that medication. And I think there were observational study published in last month with 63 patients enrolled, but it was a single arm study. Only proved safety for the treatment, but I think the efficacy is still on the way. And I'm so glad to hear that you have a clinical trial on interleukin 6 receptor inhibitor. So I think we can hear about the results of your clinical trial in a short time. Thank you.
Okay, thank you so much, Doctor. And so Dr. Salguero, yes, if you have any question, please. Sorry, you need to unmute yourself.
Sorry, okay.
Oh.
Hello, thank you for sharing your experience with us. I'd love to know the rates of use of ECMO and the criteria you use to put patients in ECMO, please.
Okay.
Question, Professor. So in our Chinese guideline, the indications of ECMO, the indication of ECMO is well the WHO for prone ventilations and other evidence-based medical strategies. In our guidelines, the indication include when the fraction of inspired oxygen is up to 19% and the oxygenation index is less than 18 millimeter of mercury for more than 3 to 4 hours. For the patient with only the respiratory failures, when the airway platform pressure is greater than or equal to 35 centimeters of water column, the VV mode is preferred if the circulatory support is needed. Circulatory support is needed, the VV mode should be used. And when the underlying pulmonary function show the sign of recovery, and the withdrawal of the ECMO can be tried. And the goals for maintaining the oxygenation and ventilation during the VV ECMO are the same for the patient with the respiratory failure due to the novel COVID-19 patient as for the non-COVID-19 patient. So in the absence of any significant gas exchange in patient's line, which can occur with ARDS, the VV ECMO flow must be at least 60 to 70% of the cardiac output in order to provide adequate peripheral oxygen saturations. For example, it should be greater than 88%. It can be best to accomplish by maintaining adequate ECMO flow similar to the normal cardiac output. For example, 3 to 4 liters per minute. In our Asia people, the COVID-19 patients may require more sedations than some other critical ill patients. Higher sedation required in COVID-19 patients, maybe due to their younger age or their higher respiratory drive and increased clearance caused by other medications. And in our practice, the RAS scale of -4 to -5 are the target in those who with ECMO, and sometimes we should require neuromuscular blockade. Sorry, I can't figure out the actual rate of the usage of the ECMO.
Yeah, we actually don't know the exact rate of the ECMO because it's not a common usage for the COVID-19 patient. It's only in the patient who cannot survive in the mechanical ventilation. That's all.
Thank you.
Okay, thank you so much.
Thank you. Thanks a lot.
Thanks, Doctor. So, Dr. Philip Eric, so do you have any question? It seems maybe we have some difficulty connecting with Dr. Philip. And now we can go back to other doctors. So, Dr. Cravo, do you have any questions? More, please go ahead.
Hello, are you here? You hear me?
Yes,
exactly.
Yes.
Okay. I would like to know about the role of corticosteroids in COVID-19 treatment. What are your experience with corticosteroids? Did you use it in the early phase or in the late phase, or you don't use corticosteroids at all?
Yeah, okay, I'll take these questions. Actually, we did use the corticosteroids in fighting with the COVID-19 patient. As you all know, the corticosteroids are the common used anti-inflammatory drug, and it's always very controversial for the viral pneumonia because we all got some experience from the SARS in 2003, and also we got some experience from the viral pneumonia like flu, influenza pneumonia. But most of the protocol guidelines from the WHO or from the IDSA of America, they all not recommend use corticosteroids in COVID-19 patients. But in our experience, we actually use some corticosteroids in some severe or critical ill COVID-19 patients. As you know, we have to use the steroids very cautiously because the corticosteroids, they may have some side effect. We need to measure the glucose, especially for the diabetic patient, and also for the patient who have some underlying disease like maybe hypertension, maybe they may have some bacterial infection or some fungal infection, or they may have some tuberculosis. For this kind of patient, you need to be very careful when we use the corticosteroids. So for the dosage, we need recommended use the dosage with small or moderate to 1 milligram very short period, maybe less than for 3 to 5 days. And for the steroids, we actually think it may helpful in some kind of patient, especially in the patient who have septic shock or have ARDS. So we recommend you could try some steroids, but you need to be careful. Thank you.
Okay, thank you so much.
Thank you very much.
So again, Dr. Philip, can you hear us? If you could hear us, please go ahead by asking a question. If you cannot, I'll just have other doctors to raise their questions. Okay, seems still Dr. Philip have some technical issue. So now we would like to go to Dr. Moboy-san. Yes, doctor, if you have more questions, please feel free to
Okay, I have another question. In the same line of the first one, when the patient is having a respiratory failure from COVID, from time to time, we have to think about bacterial pneumonia. One question we usually ask is, when is the correct time to think about bacterial pneumonia? And here we are using in our institution, beyond the standard hemogram, we are using all, beyond the white cell counts, we are using also reactive C protein and procalcitonin in order to see a differentiation whenever we think about the bacterial pneumonia. But from the mechanical ventilation standpoint, we think that there is a change in the mechanical parameters, mechanical ventilation parameters, the respiratory mechanics change from the COVID pneumonia to the bacterial pneumonia. I'd like to hear, what do you think about the problem with mechanical ventilation? Do you see the same trend, the worsening in mechanical, respiratory mechanics change whenever the patient develops a bacterial pneumonia? Thank you.
Okay, well, it's a really long question. So the doctors from China fully understand the question?
If not, I can synthesize the question.
Yes, could you please ask it in a more simplified manner to make sure we fully understand it?
Sure.
Thank you.
Sure. Do you see any changes in respiratory mechanics when the patient develop bacterial pneumonia during mechanical ventilation?
Yeah, I probably try to answer your question, and maybe Dr. Li will answer more. So I think the COVID-19 patients, they normally the co-infection with bacteria rate is very low, and we similar as yours, we also use the white blood cell and also using to differentiate with the virus and the bacteria. And also, I think when the patient was wanted of the patient is similar like the other disease who gets the ventilation associated pneumonia, I think we normally, if the COVID-19 patient, you know, they normally have very dry cough, and we don't have some evidence for the pathogen. But when you ventilated this kind of patient, you can easily to get more sputum, or you can also do some bronchoscopy and even the broncho lavage. So we suggested you can send more samples when the patient was ventilated. And I think for the parameter of the ventilation, we probably can see some the elevated of the airway pressure, but I think actually in some COVID-19 patients who have no bacterial co-infection, they also can have some very high airway pressure. So that is not a very good evidence, because for example, one of our patients who was ventilated with mechanical ventilation, we find they have very high airway pressure, and we actually did a bronchoscopy to try to clear the sputum for him. But when we did the bronchoscopy, we found that there are only very small amount of the sputum. So I think the pathogen is very important for this kind of patient to differentiate it from the bacterial infection. And Professor Li, you maybe add some more comments.
I think when the patient put on mechanical ventilation, first we got relatively optimal compliance, lung compliance. But as long as the hypoxia progressed, and I think ARDs also progressed, and we found that the lung of the patient are hard to ventilate. They're as hard as stone, and we have a high airway pressure and high glottal pressure. Maybe they need higher PEEP than normal patient who was ventilated based on COPD or other pneumonia. So we have got some problems with mechanical ventilation too. So it's very glad to hear your opinion for this patient. Thank you.
Okay, thank you so much. Yes, please.
Well, we have the impression that in the first phase of the disease, the patient has a very compliant chest wall, and then whenever it infects with bacterial pneumonia or it starts to develop pulmonary fibrosis, the compliance tends to go down, and maybe this is something that could aid in the diagnosis of bacterial pneumonia in the middle of the inflammatory storm we observe in these patients. But again, I agree with you. It's very difficult. Thank you.
Okay, thank you so much, doctors. So, Dr. Emmanuel, do you have more questions?
Oh, yes, please. In our institution, sometimes we try not to intubate our patients, above all the younger ones, using high-flow nasal oxygenation. And I'd love to know if you had some experience with high-flow nasal oxygenation in your institution. Thank you.
Actually, we use the high-flow nasal cannula and the NIV to treat our patient in the first stage, just as the professor mentioned about. And then actually our patients, if we can't. If the patient can't improve in 3 to 4 hours, then we may intubate the patient.
Yeah, actually, in our experience, we tried in some of our patients in the early stage. We use a high flow nasal cannula, and most of our patients, they didn't got a very good result. So we may change the high flow nasal cannula to maybe it's even worse than the non-invasive mechanical ventilation. So some of our patients, we may change to the invasive mechanical ventilation. So we probably only tried less than 10 patients for the NF HFNC.
It seems the doctors from Brazil all agree because they keep nodding like this. Okay, thank you so much, Dr. Emmanuel.
Thank you.
So other doctors, yes, other doctors, gentlemen, if you have any question, you don't need to wait. You can just jump in and ask them. Feel free to ask the questions that you still have. Dr. Santos?
In China now, is there any system for performing IgG or IgM serology to define humoral protection with neutralizing antibodies in the routine, or to release the patient and or employee to work, something like this?
So let's just give the doctors from China a few seconds to fully to make sure that they fully understand this question.
So
yes. So if the doctors, Dr. Lee, you understand, right? Yes. If you don't need further information, you can just go ahead and answer it.
In our seventh edition version of our Chinese guideline, it said that the NCP virus specific IgM become detectable around 3 to 5 days after the onset, and then the IgG reaches the duration of at least 4-fold increase during the convalescence compared with the acute phase. So if the titers is 4-fold increase of the IgG, and then maybe this employee or patient came back to work. And when we talk about the neutralizing antibody, so recently a research from Shanghai scholars had published a paper, and it says that this research from 175 rehabilitation patients found that the neutralizing antibodies peak 10 to 15 days after the onset of patient, and then remain stable. And but in their research, 30% of patients produce very low neutralizing antibody titers. Among them, the antibody titers of 10 rehabilitation patients didn't reach the detectable limit. The 2 patients had very high neutralizing antibody titers, but no antibody-related adverse reactions occurred. So that's my answer.
Mm-hmm. Yeah, thank you so much, Dr. Lee. And also Dr. Santos, because here in China, we have 7 different versions of treating patients with COVID-19. So I heard, I don't know, I wanted to confirm with the doctors from Peking University, right? So for each of those versions, they get updates, they get improvements based on some experiences they find at the front line. So if you have interest, or if you want to take a look, I think you can still find the full text of it online. So maybe that could really work as kind of a reference with some of those numbers that they have it in those the 7th edition of the guidelines. So for other doctors, yes, if other doctors still have questions, please feel free to go ahead. Dr. Lewis, yes.
Yeah, thank you again. But I would like to ask you, how do you think about the systemic anticoagulation in the patients with severe COVID that goes to the ICU? Do you see a role for systemic full anticoagulation?
Sorry, can you say it again?
Pardon, please.
Can you Yes, could you repeat your question with some analysis because we don't quite understand?
Sure, sure. We see that in COVID disease, there is a increased activation of the coagulation system. There are reports that about 40% develop any form of venous thrombosis or arterial thrombosis, whatever coagulation alteration. My question is, how do you see the utilization of systemic coagulation with heparin or other drugs in these severe patients with COVID?
Thank you for your question, and I would like to answer the question. Based on our clinical experience, some of the COVID patients will present with the activated dimer or ferritin or some other evidence for a hypercoagulation state. So we have also found one or two of our patients with necrosis of four extremities, and we believe that that's also caused by a hypercoagulation state. So we tried in our patients with heparin or low molecular weight heparin with prophylactic doses, and for the patient who is confirmed thrombosis, we use like a full dose heparin for those patients. But we still we have to emphasize we have limited experience at the initial stage of the COVID pandemic. So we have only tried maybe less than 20 patients with that treatment. But now we have found some more evidence from a study globally. For example, from WHO, there's recommendation for all hospitalized patients with COVID to receive heparin or low molecular for heparin or other anticoagulation agents. For those who have confirmed evidence, we have full dose recommendation, and for those who do not, maybe intermediate dose or prophylactic doses. I think there are studies also shows, especially for those severe or critical cases, heparin can improve the in-hospital mortality rate, especially for those with elevated dimer or those who were intubated with mechanical ventilation. Thank you for your question.
Okay, thank you so much, Dr. Lee. So due to the time limit, we may have only time for the final few questions. So gentlemen, yes, if you have a question, please feel free to go ahead. Dr. Victor?
Thank you. I would like to know about the hospital criteria for discharge patients. If there is any special consideration about moving the patient from the COVID-19 to a non-COVID-19 area, or you still keep the patient until his discharge in isolation? What's the political about this?
Okay, thank you. So what is the criteria for discharging a patient with COVID-19 when he or she get recovered? Mm-hmm.
Thank you, Dr. Victor. I'll take this question. I think from the treatment perspective, and we have relatively strict criteria for patient discharge from isolation unit. There are several of them. First of all, the patient has to be like a normal body temperature for at least 3 days. And the second one was that the remission of lung lesion. The third one would be we have to take like double PCR test before discharge at more than interval of 24 hours. So after that, the patient have to be quarantined in a designated spot for another 14 days with another double PCR test before he or she can be released to community again.
So in total, there will be 3 PCR tests conducted, 2 in the hospitals before
that would be at least
they were sent.
Mm-hmm. At least 4. Yeah.
At least 4. Wow.
May I?
Yes.
I wrote a paper about the situation in China that you actually use four CPRs, and I wrote about a new high levels of COVID-19 CPR in patients with IgG. I wrote about 3 patients in China with this situation, that there is another high level viral load, and we don't know for sure if is there any meaning about reinfection or not. So what do you think about it?
Just to clarify, you mean reinfection of the patients? Is that correct? Dr. Victor?
Yeah, sorry, have a problem with my mics. Yeah, because there is some patients that even when they has IgG, they also has an increased level of CPR in the blood samples, especially in those patients in China, because they stand 14 days after the first measure. So what I would like to know what they think about it. Is there any clear signification for this high levels again, or how they manage with this?
Thank you, Dr. Victor. I'll take this question. I think your concern is mainly based on the prolonged viral shedding time. I think we face with the same problem during our treatment with a COVID patient. Basically, I think the IgG and IgM will present in the plasma of the patient after maybe 5 to 7 days of initial symptom onset. Then I think the viral loads will be brought down to a relatively low level. But some of the patients who will be tested repeatedly during their hospital stay with a relatively high viral load, that was one of our concerns too. But I think, as reported, the viral shedding time might be as long as 60 days. And some of our patients will exceed like 30 days. So they have to stay in the hospital for a long time. And, but there are some evidence showing that if we perform like a viral culture, all of the culture were negative. And there is a recent report from China that we have 300 or so asymptomatic patients ruled out from Wuhan city. And all of them showed a negative viral culture result. As for now, we have no further evidence for those patients or like suspicious patients with tested like positive PCR test who were reinfected with symptom onset for those recovered patient discharged from hospital. Thank you.
Thank you.
Okay, thank you so much, doctors. Dr. Santos, do you have more questions?
No, I don't have any questions.
Okay, so other gentlemen, do you have more questions? No?
I have a last one question I'd like to ask the doctors.
Mm-hmm.
How long do you see the better? How do you see the process of recovery after ICU of these patients? How long do these guys go to rehabilitation, stay in rehabilitation?
Actually, we have no idea about this question because we come back from Wuhan So we only know that this kind of for the critical ill patients, they may take a long time for rehabilitation.
Right.
Thank you.
Okay, so thank you so much, doctors. If the doctors from Brazil don't have more questions, I think we're just going to wrap up today's dialogue because this global pandemic is a global challenge that can only be tackled with international cooperation and also solidarity, and that what made today's dialogue so special and meaningful, I think. So hopefully the exchanges of ideas and also experiences shared among doctors between China and Brazil can help both countries to better fight the pandemic and also better combating this battle against COVID-19. So thank you so much again to our doctors, both from China and also from Brazil, for your time, for your contribution and your insights. And a big thank you to our followers for your time and for your submissions. So we'll have more to come later this week. So thank you so much and bye for now.
Thank you.
Thank you. Bye.